Good evening, everybody. Thank you for joining us this evening and welcome to our orthopedics webinar series. My name is Elise Hilskamp, and on behalf of Premier Health and Premier Health's orthopedic specialists, I would like to thank each of you for attending this evening. We're very glad to have you with us. Tonight, we are here to discuss shoulder pain. As you probably know, shoulder pain is a very common issue for many, so you are not alone. The good news is that there are options available to help reduce your pain and increase your mobility to get you back to the activities that you love. Our physician expert this evening, Dr. Matthew Dorweiler, will give a brief presentation on those options. He will also answer some of your questions following his presentation. To submit a question, so just a few logistical items here, there is a Q&A button at the bottom of your screen. So if you kind of scroll over the bottom of the Zoom screen, if you will, you'll see kind of a panel there. There is a Q&A button. You may type your questions into that space at any time during the presentation. There's also a chat button on your screen, but you will ignore that. We'll be using just the Q&A button for questions. We will try to get to as many questions as possible tonight. And also, just so you are aware, this seminar will be recorded, so you will receive a link to this recording via email, likely sometime early next week, should you want to go back and reference any portion of this evening's presentation. So let's start off by introducing our speaker this evening. Dr. Matthew Dorweiler is a graduate of Creighton University School of Medicine in Omaha. He completed his orthopedic surgery residency at Wright State University's Boonshoff School of Medicine in Dayton and his orthopedic surgery sports medicine fellowship from the Ohio State University. He is board certified in orthopedic surgery. Dr. Dorweiler practices at Premier Orthopedics, one of the largest and highly trained orthopedic and sports medicine practices in Southwest Ohio. The practice offers the full range of treatment options from exercise and physical therapy to injections, pain management, and surgery where needed, including minimally invasive, arthroscopic, and robotic arm knee procedures. With nearly 30 doctors in more than 12 locations, Premier Orthopedics is ready where and when you need help. So thank you, Dr. Dorweiler, for being with us this evening, and I will turn the presentation over to you.
All right, thank you so much. And can you hear me okay?
Yes, I can hear you great.
All right, well, thank you so much, everyone, for coming. I hope this is an illuminating talk for all of you. We'll briefly discuss some of the shoulder anatomy that's pertinent to the issues we're going to talk about. We're going to briefly discuss some of the most common reasons I see patients in the office for shoulder pain, and then get into some of the treatment options, both the non-surgical and the surgical options. And then we'll also touch on briefly when surgery is right for you. After the presentation, like we had mentioned, we'll have a panel discussion to hopefully get to a lot of your questions. So looking specifically at shoulder anatomy, I think it's important to understand what a bursal sac is. We hear about bursitis all the time, but what does that actually mean? So a bursa is a sac of fluid that's located throughout the body. It essentially acts as a cushion between tendons that are especially near bones. They help reduce friction. And so what bursitis is an inflammation of that bursal sac. So within the shoulder itself, there's a bursa that exists right on top of the rotator cuff tendon, sitting between the ball and socket joints and the acromion, which you can see here, which is just the extension of the shoulder blade. Looking at the rotator cuff and specifically, we talk about this group of four muscles all the time. But I think it's important to understand where these muscles are and what their function is. So if you look on the left there, that's looking at your shoulder from the back. The big rotator cuff tendons there are going to be the infraspinatus, which is the larger one, and then the teres minor is just below that. Looking at your shoulder from the front side on our picture on the right, you're going to see the supraspinatus tendon, which is on top of the shoulder, and then the subscapularis, which sits in the front of the shoulder. So these four muscles, they help provide stability for your shoulder. They help keep that ball centered in the socket when you try to get above your head. We'll talk more about pathology related to the rotator cuff here in a little bit. So what are the most common reasons that I see patients in the office for shoulder pain? I would boil it down to these four primary categories: impingement, tendon tears, frozen shoulder, and arthritis. And we'll touch on each of these here briefly. So impingement is one of the most common causes of shoulder pain that I see in my practice. Essentially, it's a pinching of the rotator cuff and that bursa that we talked about between the humerus, which is the ball of the ball and the socket joint, and the acromion. And you can see here in the picture on the right how that bursa might get pinched. So impingement can lead to bursitis and tendon inflammation, which is what we call tendonitis. So how does impingement come about? Typically, there's narrowing of that space between the humerus and the acromion. Poor posture and altered shoulder mechanics can lead to impingement. Repetitive overhead activities are a common issue. Any kind of muscle imbalance, if you have weakness of either the rotator cuff or the many muscles that surround the shoulder blade, can also lead to impingement. Additionally, as we get older, there are some bone spurs that can develop on the undersurface of the acromion, which can irritate that bursa and the rotator cuff, leading to bursitis and tendonitis. So what are the symptoms of someone that has impingement? Typically, they're going to have tenderness along the front of the shoulder, typically pain and or stiffness when trying to get their arm above the head. Additionally, pain at night as well. With long chronic issues of impingement, there can be loss of strength and motion. Additionally, difficulty with ADLs as well. So how do we treat impingement? The vast majority of cases resolve with non-surgical management, and you're going to hear this regimen over and over again throughout this talk, because it's been studied on a research aspect to really be effective at treating a lot of different causes of shoulder pain. So related to impingement, we typically advocate for a short period of rest, over-the-counter medications, particularly Advil, Aleve, if you can take it, Tylenol, if you cannot take those types of medications. Physical therapy is a very important aspect of the non-operative treatment strategy for impingement. You know, we throw physical therapy around, but I think it's important to understand what they're actually doing in therapy. Number one, it's improving your range of motion. Number two, it's strengthening of those shoulder muscles that we talked about. And then three, it can also address postural issues that subsequently develop without us really knowing that. Steroid injections are another option that we have, which can help treat some of the symptoms of impingement. And this is looking at a depiction of where that steroid is going, and it's going directly into that bursal space that we talked about. This can be done in the office very quickly. It's a direct anti-inflammatory load to those inflamed tissues. Ideally, it's going to treat the symptoms that we talked about earlier. It unfortunately does not alter the disease process, but hopefully improves the pain as well as the function. You know, best results for these injections, anywhere from a few weeks to several months, up to 6 months in some cases. Everybody's different. Everybody responds to these medications differently. So it's hard to say how long these injections work. I typically don't do more than 2 or 3 of these injections per year. Because at that point, we're somewhat masking the symptoms there. And if they're not getting the effect that we want, then additional injections really aren't beneficial. It is important to note that with these steroid injections, they can raise blood sugars temporarily if you are diabetic. So when do we consider surgery for impingement? Occasionally people with this problem don't get better with the conservative strategy that we discussed in the last slide. And if that's the case, then I typically recommend a surgery called a shoulder arthroscopy, which is a minimally invasive procedure where I place several small incisions around the shoulder. I put a camera inside of the shoulder joint, and I essentially removed that inflamed bursa or the bursitis, creating more space for that rotator cuff. Additionally, if a bone spur is present, we can remove that as well. So moving on from impingement, we'll get into rotator cuff tendon tears, which I'm sure plenty of you have had experience with, either with your own shoulders or somebody that you know. And that's because it's a very common problem. Patients over the age of 60, about 30% of them have full thickness tears. And then once we get to around 70 years of age, about 65% of these patients will have a full thickness tear. However, that's if we got MRIs of everybody walking down the street. But the reality is not everyone with rotator cuff tears know that they have one. They don't have symptoms. So some people are asymptomatic. Kind of going back to the anatomy here, this is what a rotator cuff tendon tear essentially looks like. It's tearing of that attachment of the muscle to the bone where that tendon attaches down. Tears are typically classified as acute or chronic. So an acute or a recent tendon tear is usually the result of trauma, whether that's fall on an outstretched arm or heavy lifting away from the body. Additionally, if you dislocate your shoulder at over the age of 40 or so, that's where you risk tearing the rotator cuff in the acute setting. Chronic rotator cuff tendon tears are also very common, and it's a result of tendon degeneration with time. Typically, as we get older, the tendons, they're not as healthy and they're more prone to tearing. Additionally, repetitive overhead activity can result in tendon tears. Smoking is an important factor to note here, as it decreases blood flow to the tendon, making it more susceptible to tearing. So I always advocate for patients with shoulder issues to reduce or completely quit their smoking if possible. So what are some symptoms of rotator cuff tears? Typically, you're going to have pain at rest, especially at nighttime. Shoulder problems are notorious for causing issues at night. Most patients with tendon tears are going to have pain with lifting their arm above their head. Additionally, they will note some weakness. Some crackling sensation is not uncommon when they're attempting to rotate their shoulder. And they frankly just have difficulty performing normal day-to-day activities. Typically, an examination in the office is needed for an accurate diagnosis. We typically can get a good sense of what the rotator cuff and how it's functioning based on an exam. However, we frequently order an MRI in order for us to determine the size and the location of the tear, because it does have implications if surgery is considered. So for those acute tears, or the tears that occur in a quick fashion or the result of trauma, we typically treat these surgically. There are exceptions to this, of course. If there's a lot of arthritis in the shoulder joint, we typically don't repair the tendon. If there's a lot of degeneration of the rotator cuff muscle, or if patients just aren't able to participate in the rigorous physical therapy after surgery. Additionally, patients with significant medical issues, we try to treat conservatively, just because the risks of surgery outweigh the benefits. And then what about chronic tears? How do we treat those? Typically, it's going to be the conservative, the non-operative management that we discussed earlier, the anti-inflammatory medications, the physical therapy, and plus or minus the injections. I have found that many patients can improve with these modalities. For around 3 to 6 months, we try this, and if you're just not better, that's when we can consider some surgical intervention. And how do we fix these rotator cuffs? So again, it's through typically this minimally invasive surgery that we call arthroscopy. The picture on the left there shows the camera on the left and a working instrument on the right. And then the pictures on the right there kind of show the before and after how we fix these rotator cuff tears. We essentially secure that tendon back down to the bone where it should be, using a combination of some plastic screws and some sutures to get that tendon to stay down where it should be. So rotator cuff rehabilitation after surgery is extremely important to regain the motion and strength after your repair. My typical protocol is usually using a shoulder mobilizer, which you see on the right here, for the first 4 to 6 weeks. And the reason for this is you need to protect that repair. Anytime you actively move that arm in the first month or so, you're putting a lot of stress on that rotator cuff repair. So this shoulder immobilizer helps keep that arm at rest, allow the rotator cuff time to heal. However, I institute physical therapy about 2 weeks after your surgery, where a therapist will move your arm for you. This will allow us to work through some of the stiffness that can develop after surgery, while also protecting the repair. Most patients will have complete recovery anywhere from 6 to 12 months. However, the bulk of that rehab is going to be done in the first 3 months, but patients can expect to see improvements over the course of 18 months. So it takes a long time for these to heal. So moving on to frozen shoulder, this is an inflammation of the tissue that surrounds the shoulder joint, and that's called a joint capsule. This particular problem affects patients 40 to 60 years old. Women are more commonly affected than men. The causes of this are not entirely understood. We do have some associations in terms of diabetes and thyroid problems that put you at higher risk for adhesive capsulitis or frozen shoulder, as it's called. Additionally, prolonged immobilization can lead to this. It's a frustrating problem because a lot of times it just comes out of nowhere for some patients. It's typically broken down into 3 phases. The first phase is the inflammatory phase, where your shoulder is painful and it's getting stiff. The second stage is the frozen stage, where you are stiff, but you also have less pain. Eventually, you reach the thawing phase, where your motion improves and your pain is pretty much gone. The picture on the right here kind of shows what that joint capsule looks like, and it's this inflammation of the joint capsule that causes the pain and the stiffness. The diagnosis is typically made from a physical examination. The treatment for this problem, the vast majority of cases resolve on their own. Sometimes it can take a year or 2 to fully resolve. However, I would say 90+% of patients get better without surgery. I typically recommend anti-inflammatory medications. Physical therapy and a home exercise program are helpful to improve the motion. And particularly, it's focusing on stretching to regain that motion. Steroid injections can be an important tool for us, as they can help with the pain from the disease process, as well as the stretching that is done in therapy. I reserve surgery for a very small minority of patients that don't recover with the methods that we just talked about. Again, it's a shoulder arthroscopy, or that minimally invasive surgery, where I physically release that tight joint capsule, and then I get them back into therapy, typically the next day after surgery, preferably the day of surgery, to make sure we maintain the motion that we get at surgery. But again, the vast majority of frozen shoulder cases resolve on their own. And then finally, moving on to shoulder arthritis. So arthritis is an inflammation of the joint itself. Shoulder arthritis is less common than arthritis of the knee or the hip. Various causes of shoulder arthritis include regular wear and tear, or primary osteoarthritis, as we call it. Rheumatoid arthritis can also cause some issues in the shoulder. If you have fractures or dislocations around the shoulder, this can lead to what we call post-traumatic arthritis. Additionally, chronic rotator cuff tears can lead to arthritis with enough time. So here in the picture on the left is a shoulder that's a normal X-ray. There's a nice joint space between the ball and the socket. And then if you look at the picture on the right, is pretty advanced arthritis, demonstrating a decreased joint space and a pretty large bone spur on the bottom surface of that ball. So pain is the most common symptom associated with shoulder arthritis, and most patients describe it as deep within the shoulder. Typically, there's going to be a restricted range of motion, and you can imagine, looking at this picture on the right, that there's just not a whole lot of space for that shoulder to move. Additionally, that bone spur can act as a mechanical block to motion. Grinding and crackling sound with motion are extremely common. X-rays, as you can see, help us determine the severity, but an MRI can be useful for us to evaluate the integrity of the rotator cuff, which is important. We'll talk about that here in just a second. So how do we treat this? I always begin with non-surgical management, rest, activity modification, anti-inflammatory medications like we talked about. Steroid injections can be helpful, ice or heat, whatever feels better for you, and then physical therapy to help strengthen some of the muscles around the shoulder. So when should you consider a joint replacement? Typically, it's when pain is affecting your quality of life. You're just not able to do the activities that you want to do. You are just sick of dealing with the pain, especially when conservative treatment options have failed, and then the expected results are worth the risks of surgery. In terms of joint replacement in the shoulder, we have 2 main options: anatomic shoulder replacement and reverse shoulder replacement. So an anatomic shoulder replacement is utilized when the rotator cuff is intact. We do a reverse total shoulder replacement when the rotator cuff is not intact. And that's essentially, we're flipping the ball in the socket to allow that shoulder to function appropriately. I'm going to show you some pictures here demonstrating what those kind of implants look like. So for an anatomic total shoulder replacement, you're putting the ball on the ball side and you're putting the socket on the socket side. Again, we use this when the rotator cuff is intact. So with the x-rays on the left, there are pretty significant arthritis of the shoulder. The picture on the right demonstrates what a shoulder replacement looks like. That horizontal line that you see in the socket is just a radiographic indicator because the socket is made of all plastic, so we can't see it on x-ray. But this radiographic indicator helps us know that the plastic portion is where it should be. So then what about a reverse shoulder replacement? If you look at the picture on the left here, yes, there is some arthritis. It's not as significant as the last x-ray. However, you can appreciate that the ball in the socket joint is sitting very high within the joint. That tells me that there is no rotator cuff there to keep that ball down. And this is why we do a reverse shoulder replacement. I won't get too specific with the biomechanics of this kind of prosthesis. However, by flipping the ball in the socket, it allows the big muscle on the side of your arm called the deltoid muscle to get your arm above your head in replacement of the rotator cuff. So those x-rays on the right demonstrate what a reverse shoulder looks like with the ball on the socket side and the socket on the ball side. So what else can cause shoulder pain other than shoulder issues? And that's frequently neck pain. There is considerable overlap between neck and shoulder pain. I see a lot of patients in my office with shoulder issues that their issues are actually stemming from their neck. Typical symptoms include numbness and tingling that goes into the fingers, pain that extends into the forearm and hand, additionally hand weakness. They're all common signs that your neck is the primary issue here. So when should you see a doctor? Any pain that is not relieved by rest, medication, activity modification. If you're having pain with overhead activity or pain at nighttime, any painful clicking with activity, or simply pain that consistently prevents you from doing your normal daily activity. As your physician, what are some things that I want to hear from you? I want to know about the location of your symptoms. How long have they been present? The character, how would you describe that pain? What have you tried so far and have they been successful? And finally, what are your goals? What activities are you looking to get back to? Those are the important questions for me so that we can talk about appropriate management of your expectations to see if surgery is right for you. So some questions I think it's important to ask your physician are, when will you know it is time to have surgery? Always talk about the expected benefits. What limitations will you have after surgery? Can you expect to return to normal activity? It's important to have realistic expectations for what your shoulder will be like after a particular surgery. Physical therapy discussion is always important. How long recovery is going to take? Are you going to need assistance at home? For how long? It's important to make these plans beforehand if needed so that you're prepared after the surgery. And of course, there are no guarantees that your surgery will turn out like your neighbor's. Every patient's situation is different, so it's hard to compare one patient to the next. So that is the presentation for this evening. So I guess we'll move on to the question portion.
Thank you, Dr. Dorweiler. Just as a reminder to everybody, if you have questions this evening, if you move your cursor down to the bottom of your screen, there is a Q&A button there. Feel free to click that and type in your questions, and we will be sure to get to as many as we can this evening. So our first question is, so does a rotator cuff tear lead to a total shoulder replacement, or can it?
It can. That's a great question. It certainly can with enough time. So there are a lot of factors in terms of how big the tear is, how long it's been present, what the quality of the muscle that's attached to that tendon. There are a lot of factors that go into it, patient age. Give enough time, it can, of course, lead to a shoulder replacement. But we're talking many years. So if you are in your 50s and you just tore your rotator cuff tendon and you forego surgery, we're talking quite a long time before we'd consider shoulder replacement.
Our next question is, how long would a shoulder replacement last?
Also a good question. So at the end of the day, these shoulder replacements essentially are metal on plastic. And I think that it's important to take patient age into account when discussing shoulder replacements. So on the anatomic side, where the ball is on the ball side and the socket's on the socket side, I'd like to hold off on shoulder replacement until 50s or 60s or so. The reverse shoulder replacement I typically will do over the age of 65. However, we have had excellent long-term results with both prostheses. So I think they both have pretty good longevity.
Okay, our next question is an ultrasound possible to diagnose shoulder pain instead of an MRI?
Great question. Absolutely. I frequently will use an ultrasound for patients that either have a pacemaker or they have issues with the enclosed space of an MRI. There's been a lot of research done on evaluating the diagnostic accuracy of an ultrasound, and overall, it's pretty good. Additionally, it's cheaper than an MRI. Of the two, the MRI definitely has better quality. However, ultrasound is of sufficient quality for me to make important decisions regarding the shoulder. Great question.
Our next question is, I've been diagnosed with frozen shoulder, but I never got a chance to ask if all of my upper arm pain is to blame for because of the frozen shoulder.
That's a good question. Somewhat hard to answer without a good physical exam, but I will do my best. The patients that I've encountered that have frozen shoulder tend to have very diffuse global pain around that shoulder. Again, mostly the shoulder pain related to frozen shoulder is probably going to go down to about halfway down the arm there, but it can be the front, the side, the back, the whole thing. It just kind of depends on where else your arm pain is.
The next question is meloxicam a safe anti-inflammatory drug to use to avoid pain and surgery? I've already had a total shoulder replacement.
Mm-hmm. Yeah, meloxicam is great. I frequently prescribe this medication for a number of reasons. One, it's a prescription strength anti-inflammatory medication. Number two, it's once a day dosing, which I think is great for patients, less medication to take. If you can tolerate anti-inflammatory medications, I think it's an excellent option.
Our next question is, I have pain in my shoulder, but at night it starts to move down my arm. I know I have tendon tears, and then I get weakness and pain all down my arm into my hand. Does that sound more like a neck issue or a shoulder issue?
There definitely sounds like two issues actually. There definitely sounds like to be some shoulder pathology there, but that pain that extends down to the hand makes me somewhat suspicious that there may be a neck issue as well. And it's not uncommon for people to have both shoulder and neck issues. Once we start treating one or the other, we get a sense of how much either one is contributing to the overall pain picture. So it's very possible to have both.
Next question is, I am having some trouble fastening my bra. I have stiffness and light pain at times. I do work out and can use hand weights with no problem. Is this a rotator cuff issue?
Can you repeat that question for me?
Sure can. This person is having some trouble fastening their bra. Mm-hmm. So they have stiffness and light pain at times. She works out, can use hand weights with no problem, and she's wondering if this is a rotator cuff issue.
Okay, yeah, very common with women complaining of issues related to getting the motion to appropriately do their bra. And that sounds more like that impingement type picture as opposed to a rotator cuff tendon tear. It's very possible to have both and that you have some compensation from other muscles, but my initial inclination would be more of an impingement type issue.
Okay. Our next question is, how do you treat a dislocated shoulder?
Oh man, how much time do we have? Great question. There are many, many factors when talking about shoulder dislocations. In the initial setting, whether it's in the emergency room, you typically will reduce that shoulder that's dislocated. I will see you in the office and you'll be in a sling. I don't typically do an exam in that very first meeting just because you're painful. And then we start talking about all sorts of things. So patient age is extremely important. The younger you are when you dislocate your shoulder, the higher the chance of you continuing to dislocate with time. We talk about what kind of activities you're looking to get back to. We're talking about how many prior shoulder dislocations you've had in the past. All of these factors are important when determining the appropriate treatment for this issue. When you dislocate your shoulder, you are damaging the bumper that surrounds that socket, and that bumper is called a labrum, and I'm sure many of you have heard of the labrum. And that does not heal reliably. So once you dislocate your shoulder once, it's therefore easier to dislocate it in the future, especially if you're younger. So there are a lot of different treatment options for shoulder dislocations, and there are many factors to consider when deciding the appropriate treatment measure.
Okay, thank you. I only have one more question so far, so I'll do kind of a last call if there's any additional questions. We still have time, but so far this is the only question I have left, and that is what is the shoulder replacement recovery like, and how long does it typically take?
Yeah, very good question. So in my experience, the recovery from the shoulder replacement is a little more well tolerated than the rotator cuff surgery. So to gain access to the shoulder joint, you have to take down the front rotator cuff tendon, the subscapularis, that we showed very early on in the talk. And so the bulk of the rehab following the shoulder replacement is getting that tendon to heal appropriately. So if you look at the first 6 weeks to 12 weeks, the two surgeries are very similar. So you'll be in that shoulder immobilizer for 6 weeks total, but we'll get you started in physical therapy around the 2-week mark. When I see you at the 6-week visit, we'll check your motion, start to let you do a little bit more on your own, getting dressed, not really lifting anything heavier than a cup of coffee. We'll also get rid of the shoulder immobilizer at that 6-week mark. And then I'll see you back at 3 months, advance you through therapy during that time. And then by 3 months, typically the restrictions are lifted. You'll work on strengthening, but that's when the restrictions are lifted around 3 months. And again, it's that 6 to 9 to 12 months where complete recovery takes place, and anyone can fall into that camp. But again, I think the shoulder replacements are a little better tolerated than the rotator cuff repairs.
I did have one more question come through, and it is, what is a labrum tear and what are the symptoms of it?
Yeah, so the labrum is the piece of tissue that surrounds the socket. It acts as a bumper to prevent that ball from coming out of the socket when you move your arm around. When you dislocate your shoulder, you tear that labrum, which it can predispose to continued dislocation. And that's in the younger patient population. As we get older, we get what we call degenerative labral tears. So if I got MRIs of people from 40 to 80 years old, you're going to see in your MRI report degenerative labral tears, which are extremely, extremely common. For me personally, after the age of 35 or so, in lieu of any significant chronic instability of the shoulder joint, I don't treat labral tears. And the reason is, if I fixed that labrum back down to the socket, your shoulder would get so stiff, you would hate me for it. So I would say degenerative labral tearing is one of the most frequently cited findings in MRIs in that age range that I just mentioned. However, there's really nothing that needs to be done if you have one of those degenerative labral tears. I hope that answers your question.
Okay, those are all the questions that have come through this evening. So we will go ahead and wrap up our presentation this evening. Thank you so much, Dr. Dorweiler, for your informative presentation. We very much appreciate your time and expertise.
Mhm.
I want to thank you all for joining us this evening. I hope that you found the information shared very useful. We feel very privileged to be with you tonight and hope that you consider us for any healthcare needs that you may have in the future. If you'd like to learn more about Dr. Dorweiler or his practice, Premier Orthopedics, you can visit premierorthooh.com. More information about Dr. Dorweiler can also be found on his bio that was sent with the information to access tonight's event. And should you have any additional questions for him or would like to make an appointment, his office number is both on the practice website and on his bio. Last but not least, as a reminder, this seminar was recorded, so we will email you a link to the recording should you want to go back and listen to some or all of this content again. And as soon as it is available, likely early next week, we will share the URL to access this recording. Along with the recording, we will also share a link to a short survey on tonight's program. We very much value your feedback and would appreciate if you could take a few minutes to share your thoughts with us. So, oh, you know what? If you don't mind, we have one more question that came through at the 11th hour. And since we do have a few minutes, I'd like to address it so we make sure everybody's questions come through. So this says, I have a bicep disruption and have pain where my deltoid muscle is attached to my shoulder. Should I just do physical therapy?
Mm-hmm. Yeah, it's a very common question. It would depend on your physical exam, in my opinion. So where that deltoid attaches to your arm there is the most frequently localized point for patients that have rotator cuff pain. So what we call referred pain. People that have issues with their rotator cuff, they point along the side of their arm where that deltoid attaches. So there's likely some element of rotator cuff issues there, whether it's the tendonitis, the impingement, or a full thickness tear. It's hard to say without a physical exam in person. However, if your pain is relatively mild, then absolutely physical therapy is an excellent place to start with some of the other treatment options we talked about.
Okay, I think that was the last question. So with that, thank you all again for joining us, and we hope you have a wonderful rest of your evening.
All right, thanks everyone.